Okay, well, let's get on to the first case. Before we get started, I want to thank Zeiss for putting on this great webinar here. You always see articles and lectures talking about how to detect glaucoma, how to detect glaucoma suspects, but glaucoma progression is really an exciting topic because this is what we spend most of our time looking for. We're always monitoring our glaucoma patients for progression and titrating our treatment accordingly. So really kudos for Zeiss for putting on this lecture. And thank you all for joining us today as we go through this first case report of a glaucoma suspect who ended up being a fast progressor. So this patient first showed up in 2006. He was a 48-year-old male referred by infectious disease for an HIV ocular exam. This was his first exam ever. He had no ocular complaints. And his IOP was 20 in the right eye, 21 in the left eye, a little borderline. Packs were thin, more so in the left eye than the right eye. Gonioscopy was open, a ciliary body in both eyes. And the anterior segment and posterior segment was unremarkable other than his cupping. So it was 0.6 in the right eye, 0.7 in the left eye. Now, at this point, I wasn't monitoring the patient. I only started managing his glaucoma in about 2017. So the doc at this time diagnosed this patient as a glaucoma suspect and ordered this visual field. And at the time, the doc said that, really no significant glaucomatous defects, did see maybe a little lid defect here, some non-specific defects in the left eye, and said, let's follow up with this patient in a year. And this patient wasn't always the best. He didn't show up every year for testing, but he was monitored for many years. And eventually, I see him in 2017. At this point, he's a glaucoma patient. Now I'm going to fast forward to 2022, which was one of my last exams with him. And at this point, he's a 65-year-old male presenting for a doctor-directed glaucoma follow-up. I had diagnosed him with mild POAG in the right eye, advanced POAG in the left eye. And unfortunately, this is one of those patients that's lost to follow-up multiple times, even after he was diagnosed with glaucoma. And due to his progression and a lack of adherence, he was referred to a glaucoma specialist multiple times, but unfortunately, he actually never made it to that visit. On this visit, his IOP was 16 in the right eye, 20 in the left. He's on latanoprost and brinzolamide brimonidine combination twice a day just in the left eye, and his Tmax was 22/27. As you might have guessed, by this time his cupping has increased. It's a 0.85 in the right eye, a 0.9 in the left eye with a superior temporal notch. And this is his OCT testing. So here on the left, we have his optic nerve head and RNFL OU analysis, and you can see that patient has thinning in the right eye, predominantly superiorly of that RNFL layer. In the left eye, the patient has pretty significant thinning, both superiorly and inferiorly. If we take a closer look at the quadrant quantitative analysis, we can see that thinning is worse superiorly where that patient had that superior temporal notch. Of course, we want to look at his ganglion cell analysis as well. So this is the report here on the right. When we look at the right eye, really not too much going on, but the left eye makes sense with what we're seeing on his OCT of the optic nerve head. So we have thinning on that temporal portion, more so superiorly than inferiorly, correlating with the RNFL. Of course, we want to look at his visual field, and unfortunately, unlike that first visual field, this patient does have significant defects here inferiorly in the right eye. And in the left eye, he has a pretty dense arcuate inferiorly. And if we look at the actual decibel values, we can see that there's this patch of zeros right in that paracentral region, which means that this patient has significant vision loss pretty close to fixation. So it's not great for him. Now, when we look at everything, I think we can agree that this patient does have glaucoma, worse in the left eye than the right eye. And let's look at some of his progression data so you don't just take my word for it. Zeiss has created great progression analytics. And when we look at the OCT, we have the guided progression analysis. And you can do this of all your optic nerve head scans. What the GPA analysis does is it takes your first two optic nerve head scans and creates a baseline. Now, every subsequent scan is going to be compared to that baseline here. And you could do the comparison a few ways. You could do an event-based analysis, which is basically going to look for statistically significant changes in your scan of that day to previous scans in that baseline. and possible loss will show up as orange, and likely loss will show up as red. In this patient here, from 2017 to 2022, he doesn't really have much progression because a lot of his disease occurred before he started getting OCT imaging on this particular instrument. You can also do trend-based analyses, which is basically a rate of change of the RNFL thickness. You can look at it as an average RNFL, the superior or the inferior RNFL. And you can see his rate of change superiorly is 1.3 microns per year. Now, the left eye is the one with the more significant disease. And here we can see that both the event-based analysis and the trend-based analysis are showing significant progression. So here in 2021, the patient shows possible loss. And then the following year, as the disease worsens, we can see that turns into likely loss and then a larger area of possible loss. His trend-based analysis is showing a -3 micron per year loss on average RNFL. But if we look specifically inferiorly, he has -6.5 microns loss per year. So very quick progression. We all know that ganglion cell measurements are very important now, and thankfully Zeiss has created a guided progression analysis here as well. And the same thing, you can look at event-based analysis or trend-based analysis. And in the right eye, not too much going on. But in the left eye, once again, you can see possible loss in 2021 and then likely loss in 2022. And then same thing, his rate of change on the trend-based analysis is about 1.1 microns per year. And the most important sign of progression, I think we can all agree on, is the visual field, because at the end of the day, what do we care about in our glaucoma patients? It's their vision loss. And when we look at the guided progression analysis on his visual field, it's very similar to our OCT. So it takes your first two tests and creates a baseline from that kind of almost like an average of these two. And now you're going to have all your subsequent visual fields compared to this baseline here. You can do a trend-based analysis or an event-based analysis here as well. The trend-based analysis is going to look at the rate of change of your visual field index, which is kind of like a summary statistic of your whole visual field there. The event-based analysis is more so a kind of a point-to-point comparison here. So you can see that each point is compared to the baseline over here with these little triangles indicating how many visual fields have shown a change. The left eye with the more significant disease, you can see that the slope is more negative here, and you can see a lot of these black triangles showing significant progression on at least 3 visual fields. And that's what we're going to look for in our event-based analysis, that you're going to look at each of these points, and you're going to look at the triangle symbol there. So a white triangle means it's 1 visual field of exceeding baseline variability. Half black, half white is 2, and then all black is 3 or more. When we look at a trend-based analysis, a VFI difference of 0.5% per year is considered slow rate of progression. -1% per year is considered fast progression. And if you look at just decibel values, about half a decibel per year, it's considered slow rate of progression, and a -1 decibel per year or more is considered fast progression of glaucoma. You can look at event-based analysis where you're looking for yellow or orange, red colors here. And then we could do a trend-based analysis as well. But you have to remember on your RNFL thickness that half a micron per year is considered age-related loss. So when you look at 2 microns per year of loss, that's going to be considered pathological change. And similarly, you can do the same thing with our ganglion cell measurements. But here, age-related loss is going to be considered about 1/3 of a micron per year, and pathological loss is about 2 microns per year. So thank you. Let's go dive a little bit into this case here.
Well, Dan, that was a really great case. Now it's time to open up for a fun, very quick 6-minute discussion. So I'm going to pick both of your brains here about some of the imaging that this patient had. And so, my first question for you, Dan, is just what's your initial thought of the right eye? Does it concern you? I think sometimes I get asked these questions of, what do I make of some of those changes? How worrisome is that? And just maybe quickly walk me through your thoughts on the right eye.
So with the right eye, I would say he has mild thinning, more so in that superior hemisphere here. For me, it does worry me because we know how it could turn into with the disease in the left eye. So chances are, if we just kind of leave him at this point, with no treatment at all, the right eye would worsen. But thankfully, it seems like it was pretty stabilized with just latanoprost in the right eye. So worried that we have to monitor him, but not worried that he's progressing too much in that right eye.
Yeah, I think it's tricky because you look at the deviation map and maybe you're not blown away. Then you look at sort of the thickness map and it's not as impressive as you would like. But then for me, I really go down to the RNFL thickness and try to look at the actual difference between the right and left eye. And so I think it's using all the information that you have, which is so important when analyzing the right eye. The left eye clearly has significant damage. I think there's no doubt about that. So to me, I kind of like the OCT here really to look at the right eye. It is interesting, and I'm going to ask Dr. Turano her thoughts on the GCC, because I got to tell you, I'm making a big deal about the right eye, but then I feel pretty good looking at that, and then the left eye kind of looks a little funny. It's not always what we see. So maybe your quick thoughts on that.
Yeah, certainly. I think, one of the questions to consider would be what's the signal strength on the scans in this eye, but looking at the reflectance of those scans, it looks pretty good. So I think this is good data that we're dealing with. A lot of times when we look at GCC, my other question would be, is there anything else going on in the retina to cause change? So there may be a mild ERM that's kind of skewing the data here. So that would be my first question. I agree with you. When you look at the GCC of the right eye, everything looks good and golden. Maybe one thing to consider that we didn't quite touch on is just the size of the scleral opening in general for this patient. It's got a really large cup with a large, scleral opening to match it. And that's kind of one of the things that kind of perks my ears as well, because if we do start to get some loss, how much tissue are we starting with, and how much loss are we going to have before we start to see significant changes? But
That's a
I
great
agree.
point. Great point. I always talk to my trainees about, progression in the greens. So you got to be careful about sort of green disease, red disease, which you were sort of alluding to with the possible ERM. And, I think that's, something that's so important is to really analyze and take all the information that we have. And so maybe if we can move forward, just look at the visual fields here. And I think at first, again, the left eye, I do like, maybe just very quickly, Dan, comment on what kind of visual field this is and why you like it.
And so this is a 24-2C, and this is a Cedar Faster protocol here. And I like this field because it gives you that your 24-2 protocol that we're used to, and then there's 10 additional points that are in that kind of central area. So you really get a better idea of what's going on with glaucoma's damage in the macula. And this, I think, is a great example because this patient has quite a bit of damage to that kind of central paracentral area here, as signified by these zeros with the decibel values here.
I agree. I think that it's a really nice testing modality, especially for those patients who don't really want to do, a 24-2 and then a 10-2. Some patients follow-up is an issue. So it's a really nice tool to have. You just have to be careful, I think, because sometimes there is some issues with the fact that it is faster. And so sometimes, maybe you might call into question that you're going to get some different results when you compare it to your CETA standard. Jen, I'm just curious what your thoughts on the right eye, because the right eye really struck me. Again, I was looking at that OCT a little bit, befuddled about how much damage I thought there was. And then you see this visual field. So I'm just curious what you think about it.
Yeah, certainly. And if we, think about that OCT, we had more significant change in the deviation map superiorly. And then here we have this inferior defect. So it is quite striking. Certainly the field itself looks good. It looks reliable. The false positive indicator is low. But there's definitely some curiosity here with the mean deviation being as high as it is, and knowing that we had some loss on OCT, which we know before a field defect, right? So it's certainly something to look into.
And just, I always say that, the second eye, though it may be asymmetric, it's typically going to follow a similar pattern. So if that patient's got an inferior arc in the other eye, they're going to develop an inferior arc in this eye most likely. So I think if there were superior changes, I might say, I don't know if I buy it, but I'm starting to see an inferior arcuate on that right side. And so, to me, this patient's, I'm a little more worried about the right eye. If you could just move ahead quickly, because we only have like a minute left. And I'm just curious, when you see something like this, I'm always, and I'll let you each maybe take like 30 seconds. always concerned about, when did the damage occur? We always know that there's a lag sometimes between the elevated pressures and what we see in terms of, on the testing. So surprising or not surprising in terms of the, the trend in event-based analysis based upon this patient's history? So Dan, just quickly.
Yeah, so with the left eye, we see that even in the past 2 years, on the last 2 visits, he's been having continued progression. The right eye, the progression has actually been very minimal in these past few years. Most of the progression, I think, started before the latanoprost therapy was first initiated on for him.
And Jen, your thoughts quickly?
Yeah, biggest thing to me is just I'm still a little curious as to why there's not any evidence to change on GCC. I would expect to see something there given the significance of the field defect.
Yeah, I think it's tricky. I think the biggest thing here is you got to do your testing and you got to do it often. I think that's one of the things early on for me in my career. I tried to make my patients happy and I probably didn't always order as much testing. But if we are going to really try to analyze this data over time, we need a decent number of tests. And so no matter what our patients say, I don't want to do the field, you got to do them. And OCT really can help us early in the disease, in the middle, and even late. And so you have to recognize, we got to order all the testing that we need, for our patients as often as they need it. So great job with the case, guys. And we'll move on to the second case.